thank you very much indeed for your kind introduction and for giving me the opportunity to come here today and tell you a story. And hopefully I've already been scribbling down collaboration opportunities as we go into the future, but I think that will become apparent. So, there we go. Yeah. The story of N=1, I think, is the story for me of bringing together the basic science with the clinical research and with the population health research, which I use as a very broad title. But it can only be translated if you then underpin it with an education and training program. And so all our work has been really focused on ensuring that the quality of the outcome is worth the pain of survival. I'm sure you've all bet yourself on an iron. Just imagine half your body. So it is an area where we're really very focused on outcomes. So, well, this is where we started. A long time ago now, with a young boy who had an 80% body surface area burn on a farming accident. He was smothered by his father, who was also injured in the accident, rolled. It was a farm, and so there was some interesting microbiology because they were outside at the time. And we used the latest technology where we remove all the burn because the burn drives an inflammatory response that is unique to burn injury. It's the most inflammatory trauma that you have in terms of the sort of inflammatory cytokine profiles, etc. And so we know this, and so we remove the burn to remove that driver to this inflammation and try and stop the immune system being overwhelmed. We then introduce a framework of collagen where the cells grow into the base of the collagen. It's called integra, and it's in situ tissue-guided regeneration. After a period of 3 weeks, we peel the silicon layer off this collagen framework, and then we put our skin grafts on our spray cells. And so very rapidly, by 6 weeks, we had this young boy healed and ready for home. He rehabilitated in a way that we were all very proud. He was certainly part of our family by then. His mother said, you did tell me that we need to do scar releases as he grew. I think he's had a growth spurt. Can we pop up and touch base? I could see from the clinic as I walked through the door that there was a mass in his liver. It wasn't a tight scar. It was something from the inside pushing out. And at the time of that presentation, he already had metastases in his sacrum. And so he then went through a very aggressive oncological treatment. He was one of these kids that we sort of co-locate side by side in oncology, the burst in oncology, and I go, oh my goodness, it was so, how could you work there? And they go, oh my goodness, how could you work there? So, but he was one of these kids that was just a delight, and always smiling with whatever was thrown at him. And unfortunately died despite all that was thrown at him. And I was told repeatedly that this was a coincidence and just bad luck. Well, I've kind of lived my life believing that we learn from today to make tomorrow better, and coping with this kind of trauma by knowing that we've got to be able to learn something so that the people coming subsequently don't have to suffer less. And so with that, the question was asked was, is there a link between burns and cancer? And knowing Western Australia was so world-leading in the area of data linkage and all this space that's brought you all here today, I can nag for Australia and England combined and tell you I nagged. And I nagged and I nagged until eventually I got a message from one of the team that said, we just had a quick and dirty, and we've looked at the breast cancers, and there's no difference in incidence, but the outcome is different if they've had a previous burn. But the numbers are so disparate, with 14,000 breast patients and only 120 female burn patients, because 70% of our burn patients are male, that we need to really take this seriously, and we need to have a look. And so we had an NHMRC grant. We published this around the world because I wanted to know, has anybody else had this experience? And it was interesting because a few of the old guys like me said, I remember a case like this. And so we were all looking, our attention was looking at major burns. And so we got, again, feedback from different places. And you may think, what on earth is this guy doing here? Well, this young boy had a skull injury, and 18 months later we had leukemia. Coincidence? Bad luck? Who knows? And so, asking this question in an environment, as I say, that could answer this question is so important to me at the time. And I can tell you that the answer is yes. If you've identified as having hospitalization for a previous burn injury, you will have a changed life risk of malignancies. It's not skin, it's all sorts of different malignancies. It's not like, you know, a sunburn melanoma story. But the startling thing about this whole business was when we were looking at the data of 34,000 patients with 120,000 comparators from an age, sex, geospatial, socioeconomic perspective, that 96% of these children and 84% of the adults were non-major burns. Now, I consider a non-major burn less than 20%. So for clarification, if I had a burn from my hip to my toes, that's 18%. I think you probably all think that's pretty major. But anyway, you know, so the vast majority of those burns is less than 5% body surface area, which is probably mid-forearm to my fingertips. Yeah? And so again, these are the burns that require hospitalization, but in our headspace, they are non-major. And so, what is going on here? And so when we're looking, we started with the data, started looking big, let's look at the whole mortality, let's take the layers off the onion, and there was an increase in mortality. And in the children, it was related to about a third was infection, a third were other injuries, and a third were malignancies. But the pattern was different in the adults. And so we were criticised pretty roundly for this, and it was very challenging to publish it until we linked in with others and said, well, can we link in with other areas where there's similar data, and Aberdeen, and James Boyce was a great collaborator, we linked there, and it didn't take the answer away, it strengthened it, and so it strengthened the story that there was something going on here. But then we started looking at a whole series of ICD codes, and so cardiovascular is a classic one for us. So we looked at our population health studies, and we said, well, okay, if you survive this burn injury, what is your lifetime risk of heart disease? Because we saw the mortality in the over 65s was reduced. For example, if you were 65 and you'd identified as having a hospitalization for burn injury, your life expectancy went from 12 years to 7. So there were real numbers. And so, again, we had trouble getting people to listen to us around this at this point in time, but we saw that myocardial infarct, cardiovascular accident, stroke, left ventricular failure, hospitalizations, length of stay, and death from all increased if you had a previous burn injury. We do run parallel, by this time we were running parallel with a series of animal experiments trying to understand and explore the mechanism. And one of the animal experiments we did where we looked at echocardiograms of the heart of the small animal, and then contacted our mates in the cardiology teams at Royal Perth and said, well, we've got this finding that at 6 weeks, with a 4% body surface area burn, we've got intraventricular hypertrophy. Is that a problem? And they were sort of like, yes, that's interesting. That's interesting to us. And so we've been collaborating, again, around different clinical cohorts, trying to understand what it is that's going on here. In our major burns, one of the more recent therapies is using beta blockers just to stop the persistent tachycardia. Will that have any long-term impact? We don't know. Then we've just done a prospective randomized trial where we've given 6 weeks of celecoxib versus placebo, trying to change this trajectory. It's too early to tell whether we have or not, but we're able to see how we can modulate that early inflammation in that particular group. So this is real for us, and but what can we do about it? We've had conversations earlier this week about colchicine. We've run a clinical crossover trial in exercise and downstream, so we are very aggressive exercisers. In burns internationally, early mobilization is considered to be 6 weeks. In our burns units here in Western Australia, it's 48 hours. And so we're renowned for that, and the results that have come on the back of that. So we've gone back to the table and done Greek work, looking to see if we can change this inflammatory trajectory in people 1 year post-burn, 10 years post-burn, with an exercise program. So we came with this, that the scar is abnormal. This is where we started. We thought that the scar was abnormal. It's architecture, its chemistry, its cell phenotype. So is this abnormality such that it's tolerated by our immune system? And so we've got altered immune surveillance. Is it an innate immunity issue? Is it the surveillance issue? But what is the role of the cellular senescence and stress? And so there's a lot of things on the table, because in fact, I've spent my life looking at trying to reduce the scar, and certainly we've spent a lot of time trying to reduce the inflammatory response, reduce the immune disruption. But despite all our efforts, we see that the skin disturbance absolutely changes that breach in skin integrity, allowing that sort of bacterial flora and all other stimulation chemistry in there really is very hard to control, because we need the inflammation to heal the wound. And without that, we won't get the wound healing. But how do we modulate it so it just doesn't keep on climbing and overwhelming our immune system? And so this is the problem. This is a patient I saw in 1985 that actually changed my life. It defined what I've done for the last umpteen decades, because this boy was referred to the burns unit I was working in, my first ever burns unit, with a tag, well, we've got it healed now, all he needs is plastic surgery. And I thought, well, no, what he needs is actually regeneration. So having spent a significant period of my life in this space where using cell therapies to try and reduce scarring, we have done so. So 80% of these kids, particularly, around 65–55% of the adults have no visible scarring. There's no macroscopic scarring. I can identify where the burn has been because the neurology is abnormal. If you look at with OCT, optical coherence tomography, you can see the vasculature is abnormal. But for macroscopically, these kids look fine. So is it the scar or is it something else? And so we've been very aware of the cutaneous scar, closing that down. Very aware of the psychological scar and closing that down. But now we've got this physiological scar that is affecting every body system that we've looked at. And so with our big data work, we've published around 40 papers in this area, looking at adults and children, looking at neurology and gastrointestinal problems, looking at infection, diabetes, and wherever we look, we see a problem. One of the fascinating things is we see a 6-fold increase in mental health diagnosis in young adults who've been burned before the age of 4, when they have no potential memory. That's clearly that trauma is causing some physiological scarring, and so trying to understand that is so important to us going forward, because if we understood the mechanism, could we mitigate against it? And so what are we doing? We're looking for a needle in a haystack, but we need to change the size of the needle and the size of the haystack. And so we've engaged in a lot of collaboration in lots of different spaces, some good, bad and ugly. And one of the experiences was with IBM Watson Drug Discovery Platform. I chased these people around the US when we could travel. I was going over to do for a conference in Perth, and I'd go and try and find these guys, the research team for IBM Watson, and eventually they came to Perth. It was a bit embarrassing because there were more of them than there were of us in the room. And they tried to teach us how to use this platform, but it's no longer available because it was actually really interesting and very hard to do. And they're back at the bench. And so this is a platform that had ingested all the world's medical literature, patents, clinical trials, all sorts of things. And I wanted to ask where the link was between burn and cancer. And they said, oh, we could show you where you find the genes of interest, and you can see if the green dots are unusual or different. And so when I could sort of get this map, I put in cancer of different kinds, we put in burns, and we could see the different pathways, we could see the different genes that were sort of involved. But again, it was then, okay, we've changed the needle in the haystack size, but we've still got a serious piece of work ahead of us trying to delineate what's going on. And so we've started with different small cohorts, And this is work done with Jeremy and Elaine down at the Phenome Centre and their team, trying to look at the disruption in a small cohort of children. We've got a cohort that have a celecoxib trial, got a small cohort of children, and these pilot cohorts are underpinning what we will do with our biobank specimens. We have now 180 children in our paediatric biobank. We started in the adults in September. We've got 48 in that, and our goal is to get 1,000 in 500 and 500, so we've got some serious numbers to deal with so that we can understand some of this, the impact of the personal phenotype as well as the impact of the injury. And so guiding us, we're using a group of children that we collected at the PMH, and there were 50 of them, and we've used the cohort studies, specimens of the normal children, and you can see here that the non-burn cases are the red and the healthy are the blue. And when you start to look at the different pathways, and you heard about that from Jeremy this morning in the COVID, one of the really interesting things is in this long COVID, we see a long burn pattern emerging, which is really similar. And so we see that serotonin is disrupted, the tryptophan pathway is disrupted, and so this is guiding us into our secondary investigations, targeting which molecules we can use to distinguish these groups. And in fact, some of them have, this is the lipid profiling, and so the lipid profiling again links with the inflammation and gives us an indication into which mechanistic sort of pathway to investigate in our animal models. And so this clear difference, but what I should have pointed out in my hurry to get to the finish line here is that this is a cohort of children that I sent invitations just before we left PMH to go to PCH. And I sent an invitation to come back if they'd been burnt before the age of 3. And they were between 5 and 8, so they're all at least 3 years post-burn injury. And none of them are major burns. And only 2 of the 50 had visible scars. And these are the changes we see at least 3 years later. So there is a level of sustained change. And so one of the interesting things here, which I think I'd say here it is the difference between the healthy and the burn, but there's a difference in the burn cohort when half of them have got vaccine amnesia. And so again, went back, made sure we linked with the data around their vaccinations. They had their vaccinations, but they demonstrate no evidence of that. And so you can start to see this difference in the burns cohort as well. So we can distinguish between non-burn and burn, and then we can distinguish in the burn a more vulnerable population to the rest. So try to hone in our understanding, so really focusing essentially in the future in personalised medicine. And this again shows the ones that have not responded to the vaccines below the line, and the ones that are non-responders in the red, and the responders in the green. And so we can split this population based on their lipid profiling as well as their amino acids. So we've therefore, as I've said, driven the biobank pretty aggressively because this is the indication we've got on a very small cohort. We now have got all comers coming into the biobank, trying to look at urine, stool. The gut microbiome, I think, is essential in this case, where hair and blood. The hair, we take a centimetre closest to the scalp, and we're measuring the cortisol in there to give us an indication of the average cortisol over a month, and as an indicator of stress at that macro level. As I said, well, the majority of boys, by the time it gets adults, it's well over 70%. And our sampling is really focusing on trying to understand as much as we can about what is changing with this inflammation and how we can actually mitigate against it so that it is not accumulative over life and leads to an altered life trajectory in terms of malignancy, cardiovascular disease, mental illness, and etc. and so on it goes. We link it with obviously the clinical data and outcome data. POSAS is a patient observer scar assessment tool, for example. Our PEDQL has been interesting. We've used the PEDQL quality of life so we could link and compare with other pathologies in children. And in the children we see that the girls tally with their parents more frequently than the boys, but there is differences in how they cope going forwards. Even in these ones, the injuries that have no visible scar, they certainly have the trauma from it. And so from our perspective in coming here, it's the data and these studies have made this possible to this point. It's just, as I say, it's just the beginning. There is an enormous amount of opportunity and work to do, looking at how we can link link these burns into a retrofit into a cohort where we consider them to be moving into a normal life trajectory, whatever that may be. But then it gives us an opportunity for comparison, because there's very little we can take from a child or an adult before they were burned. However, there is some opportunity within the studies. For example, already in the origins, we have two children in our biobank that are in origins. So for at least two people, we have got specimens before they were burned. That is gold. So it makes these things possible. It makes answering the questions that have been so difficult to answer to this point possible. Not just we've got advanced analytics, we've got advanced data capability and analytics as well. We've got advanced analytics, I mean, in terms of what we can measure, whether it be the lipids profiling, the cytokines, the amino acids, the proteome, and so on it goes. And bringing all that together to give us that answer, I think, is a really, it means that I say to the guys, you just know how exciting this is. You're living in a time that is incredible. And so let's hurry up, because I'm not sure I've got enough time to hang around, So let's just drive this hard so we can actually change this life trajectory for these patients. But I think it's interesting that when I started to think about n=1, there's everyone is individual and unique, and if we truly want personalised medicine, we need the denominator, and this is what the cohort studies give us. What is the denominator that we're putting this person against? But it's nothing new under the sun. And so in 1676, I think there's a fascinating clinical trial that was reported where they put laced stockings on a patient suffering from leg edema, reduced his edema, went in well, and then somebody said, oh no, that's rubbish, take them off. Ulcers came back, and then they put them back on again. And this was reported. This is still what we do. So it's interesting that this goes, this whole idea of never walking away from the n=1. That's what, in an environment where you're talking big numbers of people all the time, it's the n=1 who sparks that thought. Who thinks, well, I wonder if, what about? And so every individual we see in clinical medicine has a story. And it's our privilege and our duty to listen to that story and not walk away from it. Not say, oh, coincidence or just kind of bad luck, live with it, but to actually take it on board and discuss it, collaborate, hand that story forward so that maybe someone else, the next generation, can give the answer. And as we develop the tools that we have to this point, that have been going on for all these decades, we're sitting, I think, on a gold mine, and we just need to be able to get our picks and shovels out, together to actually answer these amazing questions that are posed by our patients. And so, as I said, this is the platform we need to drive our personalised medicine. We're all talking about it, but we don't do it. I see 10 people with a similar kind of burn. I do the same operation, I get 10 outcomes. We've got to be able to nuance this much better to that individual at that time to close down the impact for life. So, this is where I started with the quality of the outcome must be worth the pain of survival, and with a clear understanding that every intervention from the point of injury will influence the scar wall for life. And that scar now I know 40 years later, after I started this, is not just the cutaneous scar, it's not just the scar on the outside, it's not extreme makeover plastic surgery. It's the psychological scar. But it's also the physiological scar, the scar that we carry with us in our epigenetics, in our cells, that actually define us as we go forward. The acknowledgements are beyond putting on a slide. There are so many people that have helped me along this journey, some in the room, and that I think it's a testament to being in an environment where you can ask questions and answer them in a way that I've always thought, when I came here in 1987, I thought, oh my gosh, what have I come to? From a very vibrant sort of NHS, and what I've come to, as Harold McComb, who was my great mentor, said, you've come to a place where you can put rigour around it, because people stay here. By and large, and he was a great cleft lip and palate surgeon, and had set the bar actually internationally in that area for a very long time, but in no small part because he had the capacity to follow people over time. And that following people over time, and I remember as a young registrar, marvelling as people came into the clinic with their children, and he'd done the operation on them. And they'd gone on to be almost, you couldn't say that they got a cleft. And there they were, generation after generation. And it was, the integrity you put into that analysis and driving to do better. And in this environment, it certainly is possible. So thank you very much for your time.